talking about the speaking about really healthcare, the changes to healthcare, especially to Medicaid, but just want to recognize some accomplishments in the past several years as well, um, particularly revolving around the Affordable Care Act. The Medicaid expansion in particular has been really significant. Um, in ensuring, providing health insurance to people, ensuring those up to 138% the federal poverty limit. And I'll talk more about that as we go along. 40 states and Washington, D.C. Have opted to be able to provide the Medicaid expansion. Minnesota is certainly one among those. Almost 20 million people in 2025 have been using this, about 220,000 in Minnesota. And the other aspect of healthcare, which I wanted to address certainly briefly, is the insurance exchanges. In Minnesota, that's MNsure. And nationally, there are about 21 million people enrolled in 2024, much more in 2025. And a lot of that has to do with the enhanced premium tax credits, which I know we've heard a lot about, which were started in the American Rescue Act in 2021 and extended in the Inflation Reduction Act in 2022. Something I really wanted to highlight, though, is that the percentage of uninsured Americans in the United States has decreased from about 15 to 16% at the start of the Affordable Care Act in 2014, down to about 7 to 8% in 2024. And this is an absolutely stunning success, a stunning victory when it comes to trying to get Americans health care insurance. This is a graphic from the Kaiser Family Foundation looking just at the healthcare exchanges. And if you look at the bottom, it goes sequentially in years. It really starts to rise from about 10 million Americans buying healthcare on the exchange in 21 up to about 20 million, 21 million, and more than that in 2025. And this is really due to the enhanced premium tax credits that were introduced. So nearly double the number of people buying health insurance in the exchanges at that time, which again, to me, is certainly as a physician and looking at healthcare insurance, again, evidence of a stunning success. So let's go to the one big beautiful bill or the one big ugly bill in the way that I think about it. And there's some really important principles which I think are important to recognize. First and foremost, that the driving principle for changes to Medicaid was to cut spending by $1 trillion over 10 years. I can't emphasize this enough. I hear rationale for different pieces of this that go on, and I'll address it a little bit further on. But it's really important that this is really about cutting spending in Medicaid. And the only way to decrease spending in Medicaid is denying health care services. And it's really as straightforward as that. And so it's important to look at these two principles. The other thing that I think is important to keep in mind is that this bill, this one big, beautiful, ugly bill, almost three-quarters of the benefit goes to the wealthiest 20% of Americans, and nearly half of it to the wealthiest 5%. And it's just a huge transfer of essentially wealth from the poorest Americans to the wealthiest Americans. And it's just really, it just makes me feel very sad when I look at this and some of the changes which I'll address as we go along. The Affordable Care Act Medicaid Expansion Group. Again, this is a federal poverty limit of 138%, which is about a little bit more than 21,000 for individuals, 44,000 for instance for a family of four. Some of these changes I'm going to talk about because they're particularly significant and harmful. The work requirements, meaning for adults aged 19 to 64 in the Medicaid expansion, suddenly means that instead of being able to get the health care just based on your income level, they're expecting you to show 80 hours per month of either working or job training, community service, or education, or something like that in order to continue your health care. It needs to be recertified frequently every 6 months. There's look back periods. There's all sorts of things that create difficulty, especially for working class Americans to fulfill this requirement. This was tried as an experiment in Arkansas during Trump won in 2019. It was given up about 10 months into it, and it was really a failure. And what happened was it didn't increase people working. What it did do was increase the number of people by a significant number, losing their health insurance, not because they didn't qualify, but simply because they couldn't comply with you, if you will, the red tape to prove that they were still qualified to receive it. It was abandoned at that time and is now back in this bill. Adding co-pays, which for working class Americans often means they don't get the care, um, and short enrollment periods, eliminating automatic, other things that really work to decrease enrollment. And something I should have said it when I started that over the next 10 years, 180,000 Minnesotans, about 3% of us, are likely to lose our health insurance as a result of the changes that we're talking about tonight. Some of the other changes, this is just a partial list, affects the healthcare organizations and how they provide the care and how they pay for it, decreasing incentives for participation for seniors, those with disabilities, other things such as limiting retroactive eligibility, limiting lawfully present immigrants from participating. And again, this is going to cut $1 trillion over the next decade, and it will result in the loss of 10 million, likely result in the loss of in health insurance for 10 million Americans. So I wanted to show us just a kind of a snapshot of who Medicaid represents in Minnesota. If you look at this screen from the Minnesota Department of Health and Human Services, if you look to the left, the dark blue are children, the green are parents. Below in the dark green are presumably other adults, which are probably single adults. The brown are patients with disabilities, and the green right below it are those 65 and older. The disabilities in older patients represents a relatively small number of people in the circle, but they represent probably 80% of the spending on Medicaid in our state. This is looking at it by race. About 55% are considered white, about 20% African American, 3% American Indian, 7% or so Asian or Pacific Islander, and 5 to 6% are a mixture of those. Something that's considered that you don't see here are Hispanic. Hispanics considered an ethnicity. I'm not sure I completely understand how it differs from race. It's not noted here, but about 10% of the state of Minnesota is considered Hispanic by ethnicity. So that has to be factored into this as well. Looking just at the enhanced tax credits, the average for eliminating those, and I should address that the enhanced premium tax credits were not part of the one big ugly bill. Specifically, they were excluded because they sunset in 2025. So the intent was to ignore them and not renew them. This is likely to increase the cost of health insurance on average by twice as much, and 5 million Americans are expected to lose their health insurance. In Minnesota, looking at the exchanges again, there are about 90,000 enrollees who benefit from these, and the cost premiums are expected to rise by about 50%. About 19,000 Minnesotans are expected to lose their health insurance. Again, that's wrapped up in the 180,000 Minnesotans who are likely to lose insurance. This has a bigger impact on Minnesotans who are not quite at Medicare age and those living in rural areas because health insurance tends to be a little more expensive there. Kind of summarizing it, losing healthcare insurance is really damaging. People lose their care. They lose medicines. They can't get their asthma medicines or their diabetes medicines, and they're at risk for developing medical debt. It's hard to put a number on how damaging this is to individuals across the state, but by best estimates, there's probably about an avoidable death per day uh, that having health insurance prevented and not having health insurance causes. So there are an awful lot of people being harmed by this, and that's not to mention those who are in worse health, not getting their medicines, increasing debt, and so forth. The impact on Minnesota's rural hospitals is very significant. We've heard this in the news, but in Minnesota, 10 to 20% of these hospitals have stopped, for instance, providing obstetric services, and 10 to 15% are at risk of closure. Something that I think all of us know intuitively, when a healthcare institution closes in a rural community, it's not just that it's a loss of healthcare for the community, meaning they have to go often long distances to get it. It's a loss of an economic, a business driver in the community. It's a loss of jobs. It really has a very profound impact on rural Minnesota when these things happen. And 10 to 15% of our hospitals are at risk for this. So what do states do to try and respond? What would the state government try and do? They might decrease services in other areas, education being a particularly large area of service for our state and for any other state. They might decrease the services for Medicaid, and they may raise taxes. or some combination of all of these. So the call to action that I have for everybody, and part of the purpose for this meeting tonight, is to think about educating Minnesotans on these changes. I focus on the work requirements because those are areas where people who are at risk for losing their health insurance have particular, if you will, um, ability to influence their keeping their health insurance rather than losing their health insurance. But there's other families, that are at risk as well when you talk about decreasing the enrollment periods or the look back periods or whatnot. So it's really trying to engage people and educate them so that they know what's coming. Most of the changes to Medicaid are going to happen starting in January of 2027. So it's difficult to help people understand that these are coming. They may not have felt them yet, but they are coming. For the loss of the enhanced subsidies, that's this year. People are already in the midst of dealing with not having those subsidies. So I think that people are really at this point in time, in spite of all the events in the national news, I think that this is a really good time to start thinking about healthcare and educating our population at it. And last but certainly not least is really helping people engage their legislators for change. At the federal level, this act went into action because of four of our representatives, our four Republican representatives in Minnesota, voted for it. And it's important that people know to be able to engage their legislators and let them know that they're not happy with this and to ask them to change. It's only fair to those legislators for them to know that the people of this state are not happy with what's transpiring. At the state level, there are other changes as the state copes to try and adjust to these changes that are very important. And those will probably evolve as we go through this year, since most of the changes may not start impacting Minnesotans till next year. And they may be changes happening in the legislature this year. Which brings me to Rose Roach's talk coming up, talking about the patient-centered care bill, reimagining healthcare and thinking about how we can rethink Medicaid and delivering healthcare um, to the people of Minnesota in a way that may be able to conserve our resources and save money and be able to continue to provide the same or close to the same level of care. Rose Roach is the executive director for healthcare of all Minnesotans, an extraordinarily experienced individual when it comes to how we finance healthcare, not just in Minnesota, but in the United States. And I'm very excited to hear from her. One other comment, for those who are nerds like me, I put the references throughout the talk in sub quotes at the bottom as well as at the end. So please feel free to look for yourself when you have a chance. I'm going to go and stop sharing now, Rose. There we go.
Great. Awesome. Thank you, Doctor. And hi, everyone. Give me 1 second here to make sure that I actually do this right. All right. Are you seeing just the slides?
We are.
All right. Well, good evening again, and greetings of health and solidarity from Healthcare for All Minnesota. I want to thank the Twin Cities Indivisible for this really wonderful opportunity to present tonight on the topic that really impacts all of us, right? It's healthcare, and why healthcare is indeed on the line and what you can do to change that. So I really think that in order for us to know where we're going to go, it really helps to know where we've been and how we got here. So I'm going to start with a little bit of history of the actual privatization of Minnesota's public health programs, because they are privatized. About 80% of everybody in Medicaid actually is receiving Medicaid benefits through a private insurer. So we go all the way back to 1981. Paul Elwood, who is considered the father of health maintenance organizations, sold what was then our Minnesota Department of Public Welfare, now our Department of Human Services, a very rigged privatization proposal. In submitting that proposal to what is now on the national level, or the federal level, CMS, the Center for Medicare and Medicaid Services, Minnesota actually led the nation in pushing to privatize public health programs. By 1983, enabling legislation got passed, giving the state agency the authority to designate 3 counties, one urban, one suburban, and one rural, that they were going to try and privatize as part of a demonstration project. And by December of 1985, they had approval to actually implement that privatization in 3 chosen counties. One actually was Hennepin. So Minnesota then turns around and seeks a federal waiver a couple years later to extend the demonstration, to let it go forward for a little bit longer, but the feds turn us down. But that same year, Congress enacts legislation that permits privatization not only to continue here, but for the entire country to engage in privatizing their Medicaid programs. In 1992, our state agency overseeing the program attempted to do a comparison and say, okay, let's look at the privatized counties and let's compare them to the non-privatized counties. Did they save us money? Did they improve quality? Did they, decrease disparities? Let's take a look at that and see whether they're doing what they promised to do. But oddly enough, that study ended up getting suppressed. The Minneapolis Star-Tribune wrote an article about the suppression of the study. You can see here they noted that a study raised concerns about how HMOs serve the poor fell on deaf ears at the Human Services Department. Why? Because the HMOs complained about the conclusion of the study. Well, an internal DHS memo gives us a little more insight, where it says, quote, some HMOs have a vested interest in keeping information from DHS because a large profit currently is being made, which would be revealed if the data were submitted accurately. Now we go a decade later in 2004, and DHS actually admits that they have no idea if privatization has actually saved any money in the program. These are public tax dollars. We deserve to know how they're being spent. So, we have a mostly privatized public health system, as I said, with very little transparency on how our healthcare tax dollars are being spent, which is really problematic in and of itself. But now we have to contend with the impacts of H.R. 1 and the retribution, as stated by President Trump recently, against Minnesota, resulting in the withholding of almost $250 million of additional Medicaid funding. Jeffrey laid out the impact of H.R. 1 specifically on the Medicaid and MNsure population, which is horrific, but the reality is H.R. 1 will affect all of us. The cruelty of the bill in relation to treatment of immigrants is gruesome. H.R. 1 prohibits Medicare, Medicaid, and CHIP, which is the Children's Health Insurance Program coverage, as well as these ACA tax credits for many legally present immigrants, while shifting costs to states by not allowing the states to receive the enhanced federal funds for emergency care to immigrants who are ineligible for Medicaid due to status, further segmenting us into these categories of who deserves health care and who doesn't. And that isn't just cruel, it puts all of our health at risk because health is public. Just take a look at HF 3439 if you want to see exactly how awful this change is, because the proposed changes are now being debated in the Minnesota legislature. Workers, my background is from the labor movement. Workers are going to see premium increases unlike anything they've seen over the past 2 decades. These premium increases, coupled with a struggling economy, means that workers will once again go backwards in regards to wage improvements, resulting in more wage stagnation and loss of buying power for the working class. This system is simply unsustainable. How is this all impacting the Medicare population? Well, a number of corporate advantage plans are pulling out of the market, and those that are staying in the market are increasing premiums while decreasing benefits, with Medicare supplemental plans also seeing a significant increase in their premium costs. And rural health. Although the bill provides for $50 billion in rural grants, remember, as Jeffrey said, H.R. 1 takes away $1 trillion in funding overall. Hardly buying anything back, is it? Decreased payments to providers means physicians may have to stop taking Medicaid patients. The change in the provider tax provision, resulting in a funding decrease, puts more than 300 rural hospitals nationwide at risk of closing. And the rise in patient cost sharing will increase the need for more charitable and uncompensated care in hospitals, which stresses their budgets and could cause even more rural hospital closures. So what are we going to do about it? What do we do to try and keep Medicaid and Minnesota Care whole, or at least mitigate as much of the harm as possible coming at us. Again, Jeffrey noted a few options, but I want to add a few more. In meeting with legislators since last summer, Healthcare for All Minnesota has stated these options for dealing with H.R. 1. Cut eligibility, unacceptable. Cut benefits, unacceptable. Cut already too low reimbursements to providers, unacceptable. Raise taxes, I think there might be a few people here be okay to do that as long as we're doing it on the right people, right? And corporations who can afford to pay those taxes. We could do the cost shifting that Jeffrey mentioned, take from, public education for public health. We have to stop with this idea that there's somehow scarcity. There is collective abundance. Stop with the either or. Either we feed kids or we give them health care. What is that? That's insane. We can and we should and we must do both. Now, number 6 is the interesting one, and this is the one I want to talk about tonight. We could just simply use the money already in that system and actually put it towards health care. We do not need to have private health insurance companies involved in our public health programs. Get them out. They're absolutely superfluous. There's no need for them to be in there. We have a successful blueprint for Medicaid deprivatization. Connecticut did it in 2012. They are the trailblazers, and doing so has been wildly successful for them on a number of levels. Connecticut results on both financial savings as well as quality improvements speak for themselves. You can see here, I highlighted the most important information on the cost savings, that it says a model of cost efficiency with per capita spending 14% lower, saving 14% in the program than the average of most northeastern states, and administrative costs significantly lower. They went from administrative costs and overhead of 10 to 15% just being wasted in the program to doing it between the state and the providers at 2.75%. A little over almost 3 cents on the dollar only versus 15. That's a lot. That is a lot of money. And you can also see here on the small graph on quality, it's one indicator that the rate at which doctors were able to diagnose cancer early rose after Connecticut deprivatized its Medicaid program when compared with New Jersey's privatized Medicaid program, which in turn, of course, when you can diagnose early and get people into treatment, it increases cancer survival rates. So as we struggle to know exactly what the cost of Medicaid privatization is, because they have proprietary clauses in their contracts, we do know the industry plays games with something called medical loss ratios. And what exactly gets classified as a medical expense versus an administrative expenditure. But the National Association of Insurance Commissioners themselves say that these managed care organizations, you call them HMOs, MCOs, ACOs, they're all, EIEAOs to me. It's just the alphabet soup, right? But even the National Association of Insurance Commissioners admit overhead is at least 15%. So in Minnesota, we know that 4 HMOs that we contract with to run the state programs have financial reserves far in excess of what is needed for insurance solvency. The excess, which is over $500 million, is due to the large nonprofit profits that they amass from their state program contracts. The reserves in excess would be even higher if the HMOs had not been using their public program profits to cover losses in their private side business. And then there's Medicare. Medicare provides also some insight into administrative overhead and waste due to privatization because we have Medicare Advantage plans that are extracting at least 14% from our public Medicare fund. And that 14% is being used for things like stock buybacks, shareholder dividends, and exorbitant CEO compensation packages, not for healthcare. Medicare Advantage isn't Medicare, and it isn't usually much of an advantage. It is the misleading name given to the privatized portion of Medicare, the portion in which tax dollars are funneled through insurance companies. Recently, the Committee for a Responsible Federal Budget has determined that Medicare Advantage plans will be overpaid by $1.2 trillion between now and 2034. And these overpayments have the attention of both Democrats and Republicans in Congress. This has become a real bipartisan concern. And then, even in the private market, a number of large corporations figured out long ago that private insurers are costly and unnecessary. In 1997, all the way back then, an article that was entitled Minnesota's HMOectomy highlighted the Business Healthcare Action Group's decision to bypass HMOs and deal directly with doctors and hospitals, concluding that HMOs waste millions on administration. They said, quote, by cutting them out, the coalition has reduced employers' health coverage expenses 11% since 1993. Oops, sorry. So, and then we look at this. So the American health insurance plans, that's kind of like I refer to them as the union for health insurers. They themselves say that the industry overhead average is about 21%. So 21 cents of every dollar in just the insurance portion isn't going to healthcare. It's going to something else. So with Connecticut leading the way and demonstrating that an HMOectomy can save 14%, the large private sector companies and corporations saving 11% by removing the insurance companies, the evidence-based data we have of private Medicare Advantage plans ripping off Medicare by at least 14%, and the private insurance companies themselves admitting that they have high administrative overhead costs of 21%, we put the first nail in the coffin of privatization. We put the second nail in that coffin due to the fact that privatization proponents have completely failed to produce any evidence that privatization does any of what it claims to do: contain costs, improve quality, or decrease disparities. And the third and final nail in the privatization coffin is the information and data that is provided by an incredible national report written by the Physicians for a National Health Program and National Nurses United, entitled Removing the Middleman from Medicaid, a Blueprint for Better Care and Lower Costs. This report makes it clear the savings for moving to a direct provider payment system within state Medicaid programs is significant. They're finding the savings could be anywhere from 10% of expenditures on the low side to as high as 17%. Now, in 2023-24, the legislature actually passed a few things that really did change the Minnesota healthcare landscape in very positive ways. Any day now, the legislature will receive plan options from the Department of Human Services, DHS, on ways to deprivatize Medicaid and Minnesota Care. They're going to tell us how to go about doing it. The Minnesota Department of Health will be providing a financial analysis comparing the current system to the Minnesota Health Plan. That's our single-payer healthcare bill here in Minnesota. And we're going to get cost studies on administrative waste and low-value care at some point also during the legislative session this year. There's even a study being done on the ACO, accountable care organizations, and other value-based payment schemes specifically for rural Minnesota. All of these are important for the public health infrastructure building that we hope to be doing. Senator John Marty and Representative Tina Liebling have introduced a deprivatization bill. It is called the Patient-Centered Care Act. The bill begins the process of moving Minnesota's Medicaid and Minnesota Care programs to a direct provider payment system, removing the private managed care organizations from our public health programs. The bill also prioritizes funding for care coordination, collaborating with community clinics. The patient-centered care bill is a key stepping stone to building our public health infrastructure. And let's be very clear, managed care organizations manage money. They don't manage our care. That's our healthcare providers who do that. So the organizing plan for moving deprivatization includes the drafting of an inside-outside campaign strategy, starting with the education and engagement of legislators through one-on-one legislator meetings. We're strategizing with them how to move the bill while also working with the community to raise the issue through stories of providers and patients who struggle due to the private insurers' involvement in the program. We plan to write op-eds, sponsor healthcare listening town hall meetings starting next summer and into the fall. And within various political party arenas, we have written deprivatization support resolutions that we asked to be brought to precinct caucuses and hope to be moving on to party platforms. Deprivatization of our public health program is our pathway to a humane and affordable healthcare system. We must go from this navigating healthcare land to this. Because every day that we delay doing so means more people are going backward due to illness. More people are delaying care due to costs and a lack of access to care, and more people are dying, and that is unacceptable. Ultimately, Healthcare for All Minnesota believes that Minnesota must lead the way by passing and implementing the Minnesota Health Plan, a single payer system that is based on values and governing principles centered on building a healthcare system that provides healthcare for all, no exceptions, and care that treats all medical needs. It's improved Medicare for all on a state level. Now, I know a lot of people think single payer, state or federal, is all pie in the sky. I get it. This kind of change is a heavy lift, but there simply is no other way to fix healthcare and to make sure that it is equitably and affordably delivered. So we have to use this time to build the campaign, implement the stepping stones, and provide a vision of hope for what's possible for our healthcare system that is grounded in our common humanity. And that starts with kicking the money changers out of the temple. Eleanor Roosevelt said, "The way to begin is to begin." So that's our charge, to begin. If you want to help us achieve true healthcare justice, then come join us at Healthcare for All Minnesota. As Twin Cities Indivisible, please consider endorsing the patient-centered care bill and sign on to our legislative letter of support. As individuals, please contact your legislator and ask them to support SF 3612 and HF 3476, the patient-centered care bill. Then help us build the strategic campaign that's going to win the Minnesota Health Plan. Go to our website, become a member, consider joining one of our committees. There's a place for everyone. Deprivatization of our public health programs begins to create health equity. And health equity is racial equity, it's gender equity, it's economic equity. Health is a public good, not a consumable good. So recognizing it as such protects public health while safeguarding public funds by ensuring those funds are used for the purpose as intended and nothing more. As us Minnesotans have been saying in the streets these past few months, I believe that we will win. Si se puede.
Thank you, Rose. There's been a few questions that have come up in the chat, so I'll just read those off. And then as other people have questions, you can put them in the chat. At some point we can shift to raising hands, but I think we'll try and get through the questions in the chat first. So one question was, I think, and this is related to maybe the Advantage plans or maybe Medicaid, but how will all this change impact elderly waiver? I don't know if either of you are familiar with that program.
So is elderly waiver like the dual eligibles? Is that the Medicaid and Medicare? Is that elderly waiver? I'm so sorry. I'm not sure I am familiar with that specifically.
Chris, I mean, if you wanted to take yourself off chat and ask that question directly with some more
It's an
context.
Advantage plan that combines Medicare and Medicaid, and it's on a sliding fee scale that pays for the room and board and for health care. And so I'm just concerned with Medicaid and how that's going to impact the care
Yeah.
my husband gets.
Yeah, thanks, Chris. Dr. Ditchler might also know the answer to this, but here's what I would say. Anything that's connected to Medicaid is under threat. I mean, everything is, because as Jeffrey said earlier, I mean, these cuts only come from denying care to people. So they're going to do everything they can to make sure people don't stay on the Medicaid, you know, in rolls, basically. So and those are called, I thought so. The Medicaid waivers are the dual eligibles, meaning you're getting something from Medicare, but you're also getting help from Medicaid. My mom had that as well when she went into assisted living. All of that is at risk. All of that is at risk. We don't know exactly how it will impact because it's going to be sort of parsed out over like the next what, 2.5 years, something like that, before we'll know the full impact of everything. They just stick pieces in. Every 6 months, something more horrific starts to happen. Is it at risk? It could be at risk, absolutely, because it's tied to the Medicaid program that's going to lose $1 trillion of funding.
And it's a county program, so each county has different
Hmm.
rules.
Yep,
Yep. I was
exactly. I
exactly
wish I
what
had
I
better
thought.
news. I wish I had better news for you, Chris. I really do.
Well, I expect
Jeffrey, you're on mute, Jeffrey. If you've got something to add, please do. Sorry.
Thank you, Rose. Um, the Medicaid, the one big ugly bill is really complex when it comes to Medicaid. There's so many different pieces and aspects to it, but they basically took every place they can to cut as much as they can from each of the pieces. And so as Rose indicated, it'll be at least a year, maybe several years before it starts to really understand the effects and the damages. What I do know about the question you asked is that to some degree, I think Medicaid was helping to help underwrite the cost of Medicare Part D or Medicare Part C rather. And so I think that that may be something which you're referring to, and I do believe that that will probably be affected as well. I had mentioned, changes that affect seniors. That I believe may be one of them.
There was another question as far as like the elderly waivers and just wondering if anything in the bills that you're talking about would help address some of those concerns with eligibility for available beds, yeah, the shortage of beds. I don't know if you have anything to expand on that.
I'm sorry. I'm looking for that question. What you mean, the patient-centered care bill? Would that?
Yes, yeah.
So here's everything is kind of a little bit indirect in the sense that, I mean, Jeffrey kind of laid that out well, just in answering the last question. So if we can save money inside the program here in Minnesota by getting rid of the privatizers, we take that money and we use it for actual care. So we start to restore where those cuts, right, are coming from on the federal level. I'm not telling you we're going to be able to save enough to completely mitigate the entire amount that's coming at us, but we can make a pretty significant dent. I mean, Medicaid and Minnesota Care here in Minnesota costs just under $20 billion a year. And if we're on the low side, 10% of 20 billion is 2 billion. And the KFF, formerly Kaiser Family Foundation, has said that they expect Minnesota will sort of max out at losing about 1.4 billion a year. So, we could really do a pretty significant offset there. Now, we will have to use some of that money to be able to make sure that the Department of Human Services is able to handle the processing of the claims and, because they're going to all take that in-house. The bill does allow for them to hire what's called an administrative services organization. They do this in Connecticut. That's not, it could be an insurance company, but guess what? They don't get to bear risk. All that means is we just pay them a set amount of money to just help process claims. That's all we would have them do. They would not be making prior authorization decisions, denials of care decision, because they're not going to have a horse in the race, right? So there might be a little bit of offset, but nothing to the degree of what the savings are. We could improve provider rates. We could make sure to save the type of programs that you all are listing in the chat and are concerned about. That's how I'm thinking about it. It doesn't specifically in the bill say once we save the money, we're going to do X, Y, and Z, because we just know we have to save it in order to shore up the program and keep doing all of the good work that the program is doing to save people's lives.
An observation I would make, and Rose, I don't have your knowledge when it comes to the Patient-Centered Care Act or Connecticut, but from my reading since I met you, thank you. What I've learned though is that the 10 to 17% savings, much of that will go back into the healthcare system. We
Yes.
live in I don't remember the name of how it is, but all the healthcare organizations are not for profit in Minnesota, which means they run on a margin, probably maybe 4 or 5%, somewhere in that range. Every little bit makes a huge difference for healthcare organizations. So yes, it will have a direct impact on it. I don't know that we can say how many beds, but I think we have enough, this is my learnings from working in Minnesota, we have enough resources, but having more resources will increase the ability of us to provide more service. Let me say it that way.
Kind of a big picture question here. So, as far as the patient-centered care bill, someone asked, what is the timeline for getting that passed? And of course, the steps along the way. One thing that we can all do, this week is to call our senator or House member and let them know that we do support that patient-centered bill. Senate File 3612, House File 3476, and I'll put those in the chat. But obviously it's not going to happen this year. It probably isn't going to happen next year, but possibly. But what is your, hopeful, optimistic timeline on passing this and kind of next steps?
Yeah, and so this is the timeline. So this year, it's true, we're not going to pass it this year, but we are going to get hearings on the bill this year. We're going to get a Senate hearing and we're going to get a House hearing. We may even pass it in a committee, particularly in the Senate, which would be good for momentum. But the way the landscape is right now in the Senate and in the House, it's unlikely that we would be able to pass it. But I think that we can pass it in 2027. I think we need to pass it in 2027, and this needs to be a part of the conversation going into the electoral season, this fall as well. And one thing that I didn't mention, and I really I need to change my slides up a little bit and make sure that I do actually put this in there. This is an anti-fraud bill. So this issue of fraud, as you all know, is huge, right now here in Minnesota. Let me tell you how it's anti-fraud. 50 years ago, we were told that government's the problem, not the solution, right? And then we just saw 50 years of starving the beast, basically. And what that has meant is we have turned over our oversight and responsibility for our public tax dollars to the private sector. And once we do that, we lose the ability, right, for that oversight and that accountability and that transparency. And so it is time to stop being silly about this and realize that government has a role and we need to be good stewards of our tax dollars. And the only way we can do that is for us, the people, through our government, to oversee this program and make sure we have hired people who are watching for any potential fraud from the get-go and can be a full-time. That's what they would do. They would be able to discover it early on, catch it, and we would have much, much less risk of anything to do with fraud. So this is also an anti-fraud bill. We are, and a whole section in the bill has actually been written to lay out exactly how it's an anti-fraud bill. So the idea is this year we use the hearings as a way to educate and to organize. And then again, we start talking about this all around the state because again, as Jeffrey said earlier, and I said as well, we are going to have healthcare facilities and hospitals, particularly in rural areas, but not only rural. Look what's happening at HCMC right in our own backyard. For those of you who are from the Twin Cities area here, we can't let HCMC close its doors. We can't let that happen. I can't stress that enough. There is no place for those patients to just suddenly be able to, show up at a different hospital at. That just can't happen. It's a trauma one hospital. So all of this is related to the potential of the loss of this funding. And so we want to use this year as an education organizing year and get it passed in 2027. We need the trifecta, and we need to ensure that whoever our gubernatorial candidate is and wins is also on board with this.
Yeah, that was a specific question in the chat, was asking if there's passing this bill, I think would make a big difference in saving HCMC, and whether it
Mhm.
can get done in time before HCMC.
Yeah, I don't think it can. I mean, I've been bugging the legislators that I talk to on a regular basis, saying you got to throw some money at HCM. Sorry, but we've got a surplus. You have got to do something to shore them up, and it can't just be the stadium tax and all. I mean, it we have to protect HCMC. I'm sorry, but we just do. That hospital is too important to our community.
Mhm. Yeah.
Is something else I like to share about HCMC Rose is that it's one of the premier teaching hospitals in the United
Yeah,
States.
that's right.
Mhm.
Thank you. That's right. Can I answer, is it Benita's
Yeah,
a
go right ahead.
question?
Yeah,
Just
see some
because
good questions.
it's an
Jump in.
easy question to
Yeah.
answer. So you're asking me, does Congress have to weigh in on this? No, we don't need waivers from the federal government to deprivatize Medicaid. We can just do it. In Connecticut, they actually did it by an executive order. That ain't going to happen here in Minnesota. They're going to want, enabling legislation. We're going to have to go through the legislative process, and that's fine. It's just two different ways of which you're doing it to do it, but we do not need waivers. Well, let me back up. We might need a waiver for Minnesota Care. We don't need one for Medicaid. And of the 1.3 million people that are in each of those programs, about 120,000 are in Minnesota Care. The bulk of them are actually in Medicaid. So we could just simply do it.
Rose, one of the things, comment that I make, I spent some time really trying to understand the Connecticut, the deprivatization. And the more I read, the more I realized is that there's really no evidence that supports that privatization using the HMO model improves care or saves money. It's just kind of what we've been doing for, 50 years as a country. But it's just really, it was just remarkable how it opened my eyes to think about it. So I really am grateful to you. Thank you so much for sharing all this.
Yeah, and I will find here in a second. I'll put in a link in the chat to that report that I was telling you all about. It's a national report on this because we've been getting it to all of our legislators every time we meet with one. We're giving it to them, and we've even brought in one of the attorneys who was involved in making it happen and out in Connecticut, and he's talked to a bunch of our legislators. He may even be one of the testifiers because it is so wildly successful in Connecticut ever since they got rid of those HMOs, MCOs, whatever you want to call them, in their public health programs that they just couldn't even dream of going back. Anybody. I mean, they have increased doctors and physicians who are willing to now participate in the program. They've been able to increase reimbursement rates. It's just been a wonderful deal all the way around. And the doctors in particular love it because they're not having to fight with insurance companies to, oh, I don't know, get us the care that they have determined we need after actually examining and diagnosing us and thinking that insurance companies somehow should know better than them. That's
Something I
crazy.
noticed about the Connecticut program is it's been around since I think 2012, something like 12 or 14 years already. I mean,
Yeah,
it's really stood the test of time.
that's right. That is exactly right. And there were companies, 4 or 5 states that never privatized, and all the rest of them did. And Oklahoma, oddly enough, deprivatized at one point, and they saved a lot of money, but then they just recently decided they just flipped it around and said, now we're going to put the privatizers back in again. And, they're seeing it go upside down by doing that. They've absolutely seen an increase in spending.
Rose,
The
do you have any
political
sense?
issues,
Oh, go.
go ahead,
Okay.
Bridget.
Rose, do you have any sense of when the bills may get a hearing in the House or Senate this session?
So right now, what the last I heard was that they are prepping a fiscal note on the bills, and they are waiting for the fiscal note to get done, and then they will do the hearings. I think they'll likely will see the Senate hear it before the House. And I am more than happy because I'm kind of liaisoning for Healthcare for All Minnesota between the authors of the bill and then the committee chairs with Healthcare for All Minnesota. I'm happy to let you know, Bridget, when I hear that they're going to get a hearing, I can just shoot you off a quick email and let you know, oh, hearing is scheduled if you guys have an interest.
Yeah, no, we'd like to know because we have, and I'll talk a little bit about this, but Indivisible Twin Cities hosts action hours where we all get together, learn about an issue, and call on issues twice a month. And we have sessions scheduled for March 10th and March 24th. And so just wanted to try and time call the
Sure,
legislatures around when a hearing would be. And it sounds like either of those would be appropriate.
sure. There's a question about how it's impacting Minnesota Care. Minnesota Care is also privatized. Again, it's the same sort of percentage, about 80%. The 20% are under what's called a fee for service, meaning literally it's already the direct contracting happening between the state and the providers. So we're just saying let's just go 100% and stop fooling around with this. But Minnesota Care, our hope is that we could deprivatize Minnesota Care at this as well as Medicaid. And again, not as much savings because there's not as big a pool. There's not as many people in Minnesota Care, but we would have some savings and we could again use that specifically for healthcare for the individuals that are accessing Minnesota Care. So that would be our hope. We may have to start with Medicaid only because I think we're going to need a federal waiver because Minnesota Care is considered a basic health program under the Affordable Care Act. And so it's got some different sort of rules and regulations around it. So we might have to seek a waiver on that. Hi, Linda. Go ahead, my friend.
Uh, are you talking to me?
Yeah, I'm talking to you.
Okay. I'm not camera ready tonight, so
Okay.
well, I have two questions. One is who from the Minnesota delegation to Congress serve on these committees that should have hearings? And secondly, what is the counterpoints from the other side to why we shouldn't do this?
Well, first of all, it's not Congress that'll do it. It's right, the Minnesota
Yeah.
legislature. So if you're asking for who are on the health committee, I mean, we think there'll be this bill, the patient-centered care bill. Oh my gosh, is going to be heard in probably Health and Human Services in the Senate and Health,
Okay.
Finance and Policy, right, in the House. So
Okay.
in the my understanding is in the Senate, you've got Senator Wickland, Senator Mann, Utke, is that how you say it?
But
Abler, Bolden, Hoffman, um, let's see, Kupik, Liskey, Port, and there's one more, and I can't read my own writing. K is a Koran, Koran. I'm not.
Coran,
Okay,
Coran.
it is okay.
Yeah.
Sorry, it's literally my own handwriting that I can't
Well,
read.
what
And I don't. Let's see, and I don't have the list in front of me of who is currently on the House committee, but you can just go to their website and just go under
okay.
committees and look for health,
Yeah.
health, finance, and policy, and you can
Tell me,
find
tell
out
me
who it is.
excuse me,
Yep.
tell me the names of the committees again, the one in the Senate and the one in the
The
House.
Senate is the Health and Human Services, so it's HHS, right?
Okay.
And then
Okay.
in the House, it's called Health, Finance, and Policy.
Okay. And policy. Okay. Thank you.
Yes, and you wanted to know sort of what are going to be the counterpoints on this. I mean, I don't think it's anything different than we constantly hear, right? It's what we've been hearing for 50 years. First of
Mhm.
all, you're going to hear, oh my God, we're moving towards socialized medicine. Oh my God, we
Mhm.
have to have, right, the private sector in here because the public health sector can't do anything right. God forbid we turn over our healthcare to them. I like to say, I don't want the government in my healthcare, but I also don't want my boss in my healthcare, and I don't want corporations in my healthcare either. My healthcare should be about me and my doctor and my family, and that should be it. Anybody else is completely unnecessary in that equation and is most likely sucking out money that is not going to healthcare and is being used for something else. And that's why we ultimately want to, right, move towards single payer. And we understand that's not happening anytime soon, but we can start to build towards it. And the first thing we do is we've got to take back our public health programs to be actual public. That is the first step. So I don't think we're going to hear any different arguments than we have ever heard. They're going to try to say, oh my God, they're going to, I mean, here's one thing I've heard. Well, we'll lose care coordination if we don't have managed care organizations in the middle of all of this. What an absurd thing to say. Most managed care organizations, when I talk to providers who have to deal with Medicaid patients that are actually, in a managed care plan, they're like, I constantly have to fight to coordinate any care with them. I want to coordinate their care. So that's why the bill very specifically allows for care coordination to not only happen, but to fund it and to make sure it happens with the people who actually provide the care. So I think, Linda, it's going to be the same old is my guess.
Well,
But I don't know.
you gave me some really good talking points I was writing. So thank you.
Awesome. You bet.
Richard, do you have a question you wanted to ask?
Yeah, I get medical assistance, and does that is it gonna will that be that the bill can affect that?
Yeah, medical assistance is Medicaid in Minnesota, Richard. So it's just the name that Minnesota gave Medicaid, but it's literally the Medicaid program for Minnesota. So yeah, it is going to affect that. And I mean, the bill will affect it in a good way if we can get this bill through. It'll help restore some of the pain that's coming at us from the federal government.
The important thing as we look to changes in Medicaid, to know your circumstances, it's really, I feel badly for all of us because understanding the nuances of this legislation are difficult. But as each of us as individuals, part of the education focus for me is to help others understand that knowing your circumstance helps you guide your way through this. And there's so many nuances to this. I wish I could list them all and help everybody. I have this Pollyanna thought in my mind that we can build an infrastructure to be a resource to help everybody figure it out so that they don't lose their health insurance or get it compromised.
Roger, did you have a question?
Hey,
Go ahead.
Roger.
Good to hear Linda's voice, yours, Rose, and nice to see
Hi, buddy.
Indivisibles finally showed up to the party. I've been advocating for this since 2006. I ran in Congress in Wisconsin for universal health care, just like all my international customers are using in most of the good countries. So get on get on the bus. But Rose, why with a trifecta? This is what irritates me the most, and I blame Tim Walz for this and Klobuchar. Why don't we already have it when we have the House, the Senate, and the governor's office? Should already been a no-brainer, should have been done. So that's my comment. You don't have to have a response, but I'm still very upset that we don't already have it. Thank you.
You mean you're saying single payer, right? Or Medicare for all, right?
Yes.
Is it right? Yeah, right. Yeah. Well, I wish I'm as frustrated as you know, as you are about this. I mean, I think the best shot we had was when Bernie was, making it really obvious about Medicare for all, and everybody was talking about it back in 2016, and then it kind of dropped off of everybody's radar. I think it's back on people's radar. Actually, I also happen to serve. I'm not doing retirement all that well. I'm also the national coordinator for the labor campaign for single payer. And in my work on a national level, I was invited into a meeting with Representative Jayapal, who is the author of or co-author of the House Medicare for All bill. She has created a Medicare for All PAC. And she actually did some recent polling, and the polling is phenomenal, absolutely phenomenal on the support at this stage of the game for Medicare for all. And it does, and of course, you don't have as many who lean more conservative supporting it, but you have more than you've ever had because people are just sick of this. In most cases, I think that, the obstacle comes at the top level because when you're actually talking human being to human being, it doesn't seem to matter. I mean, there are some obviously MAGAs or whatever that it's like ideologically, they're never going to, they want the private sector to do everything, right? But there are a lot of people who on this issue you can have a conversation with them because they're freaked out about what's going on in healthcare and they're scared and they are seeing losses for their families and their, bankruptcies and all that kind of stuff. And they're ready to have the conversation about what's next. I agree that we should have done this after World War II when every other industrialized nation in the world decided to do it and we wouldn't be dealing with this. And now the big moneyed interest involved in this, it is not going to be easy, but that doesn't mean we can't make it happen and that we shouldn't keep pushing to do it. I know somebody asked a question about when could we get single payer, at least in the state of Minnesota. I'm not being a Pollyanna here. We're going to get the funding study will come this year. That's going to help us figure out how to put the exact funding numbers into the Minnesota Health Plan bill. Hopefully, we can do that within the next year or so, introduce a comprehensive bill. And, I would love to see it passed by, and implemented by 2030, 2032. I will tell you that I'm a little worried. I mean, if, I don't suppose anybody on the Republican side would support a single payer system in Minnesota. I'm not sure that Senator Klobuchar, should she become our governor, supports single payer. So we have work to do. And we have to just make sure that we, push and make it clear that this makes sense and this is what we want and make it happen. So that'll be a little bit of a challenge, I think.
The polls I see, the majority of the independents, Republicans, and Democrats in Minnesota favor a single payer type health plan. And
Yeah.
even the people at the sales barn in Sombrota and Lanesboro and Lewiston and Cannon Falls that I hang out with, those boys are all in favor of single payer too. And they're diehard Republicans. So
I hear you, Roger. I think the
Thanks,
time
Mike.
is now. I think the iron is hot and we got to strike.
Michael, you're up next with your question.
Perfect. The question I have is I have quite a few friends and then I work in the psychology field that have disabilities, whether it's major depression, bipolar. Then I have friends that have more of the physical stuff with eyesight and hearing and different issues like that. Are there going to be any exceptions to the work rules for people that are in those situations that have like bipolar, schizophrenia? They may not be on Social Security yet. They're in that 1 to 2 year waiting period. And what's going to happen with them?
Doctor, can you handle that one?
Yes. Disabilities there are exclusions to work requirements. And disabilities, I don't have them offhand, but disabilities is certainly one of them. But it's important, the devil's often in the details of being able to document that in a way where that represents an exclusion. So again, it gets back to everybody who has this. You need to be able to navigate it in a way where you gain the benefit of having the disability and get the benefit of the waiver, which you should have.
Perfect. All right. And as far as, do you know, or you just said you didn't know the specific disabilities as of
It's
now?
mostly the things you mentioned, my guess, all fall under disabilities. But it's
Okay.
really it's the devil's in the details, and you need help making sure that when you apply for that waiver, that it's documented properly and accurately. Does
Okay.
that
Yeah,
make sense?
it does. Yeah, there's a huge fear with a lot of the patients that we have that losing their care because they're
The
not on
word,
Social Security yet.
oh, and part of what I feel for them, for all of
Hmm.
them, is because this bill is written in such a way that it's intended to try and knock people off. That's the way we save money, is by denying health care. So it really requires a detail orientation towards getting things done so that you don't lose your health care. It's a really cruel bill. This is a very cruel bill.
I agree. Yeah. All right. Well, thank you. Thanks.
You're welcome. Good luck.
Yep. Appreciate that. Thanks.
Pam, you're up next with a question.
Is that me?
Yeah.
My question is a general question. Am I understanding correctly? When you say we're having all these cuts coming to Medicaid, Are these coming from the fact that people are going to be thrown off of their programs because they can't meet the work requirements and so forth? And therefore, we are not going to get that money from Medicaid sent to our state? Or where are the actual cuts? Are they actually cutting? I'm trying to understand that. And there's some other people who've asked me about that too. Am I understanding that correctly?
So the work requirement is probably going to say it applies to the Medicaid expansion population. So if you have Medicaid, because you don't make a lot of money, that's the first thing. It's
Mhm.
usually patients 18 to 64, and it's usually if you're a healthy person without a disability or an exclusion, it applies to you. So that's probably a third of the savings, something like a third of the savings. This huge amount of the savings in this bill are from that part of it. But
Yep.
there's other things that both Rose and I have talked about and alluded to. There are ways the state finances Medicaid through what's called provider taxes, so that they're going to cut down the amount you can do there. Um, you know, there are other ways that they direct payments. So sometimes the state can increase the amount of payments for certain services because to keep them competitive with the private industry, those are being limited. There's all sorts of the nuances of and the numbers of different ways that Medicaid is limited are all there. From an individual, again, it depends upon who you are and what your circumstance is as to how affected you will be from this. And the state has to be able to look at how they're going to change their state Medicaid. I forget the name of what we call Medicaid in Minnesota. Minnesota Care. If I got that wrong, Rose, you can
Medical
correct me.
assistance.
Medical assistance. Thank you so much. So the state, we don't know yet how the state's necessarily going to have to make the changes, and that will impact obviously everybody in the program. So there's still, and most of these changes don't take effect until January 1st of 2027. So they're still being worked on at the state level, as I understand it right now. So we all have to just wait and see how it changes, and then we all have to adapt.
Right. And so the hospital closures would be caused by what?
What happens is when they cut Medicaid or then people start to lose their Medicaid, then rural hospitals, to take them as an example, all of a sudden people who had Medicaid don't have Medicaid. So all of a sudden they're not paying customers and the amount of money that's being generated in that hospital goes down. That's what leads as much as anything, what leads to them losing money. There was some money, grant money, $50 billion for rural hospitals, but that pales in comparison to the $1 trillion that they're cutting. And ultimately, hospitals, all professionals providing care, but especially hospitals, feel the pinch of that. So, as I mentioned, many hospitals already started cutting services. OB services is the classic example of ones that get cut. And we'll just have to wait and see which hospitals, how it affects hospitals.
Okay. And we have these four federal Congress people who voted for the big beautiful bill, Emmers and Finstead and Stauber and
We
Fishbaum.
do.
And it's very difficult for those of us who are not their constituents to feel like we can have any impact on what they are doing at all, even though everything they do affects all of us. So I
You
find
can
that to
still,
be a very frustrating reality. There's no point in my writing to Emmers or having anything to do with him or the others because they could don't care at all what I think. They care about their constituents in their districts. What do you have?
it's true. I would always encourage all of us that we can still fill their inbox with emails.
Oh,
We can still give them phone calls if we choose to. And we can educate their constituents to the degree that we have access to them and help them be advocates for themselves within their district.
yeah.
And
Thank
we
you.
can help with whoever their challengers are when they're running for office again.
We can do that too.
Right? We can do phone banking. We could take a bus up or a carload of us in precinct walk.
And
I
we're all
have thought
Whatever,
about
right?
accountable.
doing that. I have thought about doing that, be participating in the campaign of Finstad, the opposer to the challenger to Finstad.
Yeah,
That seems to be one way to do it, really. Thank
But
you.
it's
Thank
it's
you.
yeah,
it's
you bet.
really it's a healthy part of our democracy that people should be able to know what their legislators are
Yeah.
doing, to let them know how they feel, and to support challengers if the issues are important enough to support their challengers for it.
Yeah.
So I think it's really living, breathing democracy is the way it feels to me.
Thank you.
You're welcome.
Rita, you had a question? Oh, do you want to take yourself off mute, or I can for you?
I didn't know it came from my end. Thanks.
There you go.
I would like the moderators to clarify that we've got two things going on here. We've got the big, beautiful bill and the cuts that are looming that are going to affect us in the future, I guess. And then we've also got this universal healthcare bills that we're promoting and trying to get passed. And so during the discussions, I'm having a little hard time parsing out what's going to happen because of the cuts that are coming. And I don't want to confuse those with the things that would happen once we get the Minnesota healthcare plan, universal healthcare.
Yeah, so think of it this way, Rita. What we're talking about tonight is the impact of that HR1. I just can't bring myself to call it the name they want to call it. The impacts of HR1 mean we have to start to do something, right, in order to offset the horrors of that bill. So the first thing we do, because we're not passing universal health care in the next year or two, but what we could do is we could save some money in the current Medicaid program, and we could do that by starting to make it a real public program. And so the way we're tying this together is we're saying, first of all, the time is right for us because of the unfortunate reality of what's happening in the federal level. The time is right to actually take back our public health programs and make them truly public. And that's 1/5 of the entire population of the state of Minnesota access their health care through Medicaid and Minnesota Care, right? So now we've got this one great big pool that is a public pool here in Minnesota. Then we start to work on how do we all end up in that pool through the Minnesota Health Plan. So it's kind of, think of it as pathway and stepping stones. We're reacting to the bill from the feds. We want to save money. We can do that by getting rid of the privatizers and our public health programs, get that in place, and then we start working on how we build the next, stepping stone towards the Minnesota Health Plan. Does that help at all?
That does help. And it's fortunately, unfortunately, it's a way to get there, we hope.
Yes, exactly. That's right.
I would love to just go for the Minnesota Health Plan.
Me too.
But,
Same.
Yeah. Okay, thank you.
You bet. Sure.
Richard, did you have another question?
Yes,
Okay.
I would. And is that going to affect me if I'm working?
You cut out a little bit, Richard. Are you saying are these cuts going to affect you as someone who is accessing medical assistance but also working?
Yes.
Well, I mean, Jeffrey, I don't know. I would say, I mean, it's going to affect everybody somehow, some way. But if you're working, the biggest issue is you're going to have to prove over and over and over again that you're working. You're going to have to do all this paperwork. I mean, that's what they're hoping for, is that people will just get frustrated with it and say, forget it, I'm not even bothering with it. Or they'll just literally forget to do it because, oh, I don't know, they're trying to survive, right? And they will forget to submit their paperwork on time. And suddenly they'll lose their access to healthcare just because they missed a deadline to prove that they actually are working and they're meeting all of the new criteria that the federal government wants to put on Medicaid enrollees. Would you say anything differently about that, Jeffrey?
No, that's exactly what happens. And it's really important. Again, I've said this before, but your circumstance, you have to look at your circumstance in light of the changes and just to be sure that you're complying with what they need you to comply with to keep your insurance.
And one of the things I want to bring up too, I was going to mention this earlier because this is a big issue, right? This issue of like making sure people don't fall off of the Medicaid enrollment. So one of the things that's included in the patient-centered care bill under care coordination, it actually includes a part of care coordination is also having someone, and again, we would have to fund this, but we can, if we can save the money, fund positions where part of care coordination is making sure, Richard, that somebody calls and says, or sends you an email, or stops at your house, whatever it might be, to say, Richard, guess what? 2 weeks from now, we have to submit your paperwork again. So here it is. Let's fill it out so to make sure that you have no like drop in your care, right? That care coordination should also be about now with all of this ridiculousness, with this unnecessary, added paperwork stuff, that at the very least someone is helping folks do that so that they stay and it's seamless and they're able to stay on Medicaid and they never have to worry about dropping off. It's a really important point. And
Yes.
I just looked at a bill, I don't know if it was yesterday or this morning, but the legislature is starting to act here in Minnesota on what the feds have said have to be on these work requirements. So they're starting to spell all that stuff out. And I know there are folks it's called This is Medicaid. It's a Medicaid coalition here in Minnesota. And it has some unusual partners for us. I would say we're in the room with the Minnesota Hospital Association, and even the health plans and stuff are very concerned about what's going on with this. And so it's a pretty powerful coalition that is trying to influence how these, work requirements and things should actually roll out, and try to do them in a way that is the least harmful to people, if that's possible.
The work requirements, it's required that the states manage this. So I think,
Yeah.
Rose, that's what you're referring
Yep,
to.
exactly. Yep. So that's why they're passing legislation to do that management. That's exactly right. And I did hear that, just to make my head explode just a little bit more about all of this stuff. As you guys can tell, I'm a little bit passionate about it. But apparently, the state is already looking at hiring an outside privatizer to oversee the whole work requirement thing. And we're trying to like push back on that right from the get-go, right? No, don't do that. Keep it in-house. Hi, Deb Meyer, by the way. How you doing, sister? It's one of my nurses. I was the executive director of the Minnesota Nurses Association before I retired. Hi,
Hi,
honey.
Rose.
Hi.
Yeah, we
She's
just went up to the Legislators Day
yeah.
yesterday. Yeah,
You
so
just had your day on the hill.
we
Deb
did.
is a retired nurse from Worthington, everybody. So it's good to have her here.
Yeah, thank you for this wonderful
Good.
presentation.
Absolutely. Thanks for being here.
Well, and even some of the people on the call asked if there'd be recording. So there was a recording. I'll be sure to save it. We'll get out the slides to everyone. Yeah, this was really informative.
Good.
And I think, in this really difficult time, hopeful, it is the
Yeah.
fact that this patient-centered bill has a fighting chance in the next couple of years is really hopeful. So.
And I think that is so important, Bridget, I think that, we need to restore those subsidies that were cut just because it's the current system we live under and people have to be able to access healthcare. But we also have to realize that system is not sustainable, and we will never, ever subsidize ourselves to universal healthcare, because every time we give that industry more money, they use it against us to make darn sure that we never get universal health care, right, in this country. And so as much as we need to fight to try to get that restored, we also have to be ready to pivot and say, and now here's where we're going to go to make sure this kind of thing never happens to us again, and provide people, as I said, with hope, and as you said, hope that it can be different. It is possible to have a different reality than the one we have in healthcare in America.
Well, thank you so much, everyone, for joining us. I'm going to just very quickly try and share a slide. I did mention that we have our action hours where we call on issues, specifically issues like this. And we'll be sure to have a health patient-centered care bill action this month. And I do want to make sure everyone is aware about No Kings 3, March 28th, where we will show up in huge numbers. Minnesota is the flagship location for the National No Kings on March 28th. We'll be at the Capitol. There will be marches coming from several different places that converge on the Capitol. So there'll be lots of opportunities to get engaged. The easiest way is to sign up via the Mobilize link, which I'll share. Well, I'll try and share in the chat here in a minute. You might be running out of time, but it comes in the Indivisible Twin Cities emails that hopefully all of you are getting. Thank you so much to our guests for sharing their knowledge. The questions were wonderful, so I certainly learned a lot this evening. Thank you.
Something else I wanted to Rose, I want a special recognition for you. And I know there are many people working on this, but it takes a huge amount of work to get legislation and potential moved to this point and continue to move along. So just grateful appreciation for how much you and many others, I know many others are doing. But I wanted people to know that.
For sure.
Thank you. Same to you, Doctor. It was
Thank
great to
you.
be here, everybody.
Have a good night, everyone.
Thanks.
Thank you all.
Thank you. Take care.